what is the public utility model?
Well, yeah, I think you have to do it from whose perspective you're looking at it from.
Well, let's start with the patient, like Roberta said.
From the patient. Remember that commercial I talked about?
Yeah. Yeah.
That's the patient perspective.
Oh, yeah.
This is this is the father that walks out and picks up the minute. I don't want to be accused of gender bias. He walks out the front door, he gets the mail, he's walking back, he's looking through, sees a utility bill, opens it up. It's a regular utility bill, electric, water. Here's the crash in the house. The daughter falls down, breaks her leg. They rush her to the hospital. They're coming back, and as they're walking up, the wife's going, geez, we're a little tight this month. How much does that cost us? And he says, well, there was a $700 deductible and another $500 copay that we had to pay. So it's about $1,200. And she turns around and looks, look, we can't afford that. To the other scene where he goes out and he picks up the utility bill, he looks, he sees $50 for HealthCare on there. You hear the same crash. They go to the hospital. She comes back. The wife's asking, how much is that? And he looks down at his bill and he goes, nothing. That's the patient perspective.
Wait, I want to add to that. I think something even stronger than that is a mother holding a 5-week-old child, because my my daughter-in-law had to go to the hospital for a D&C because they couldn't get the placenta out. I just found out yesterday, I had no idea that my son paid every freaking penny of his savings account, $15,000 when he has insurance and he works as a pilot and he's fully insured. And they just wiped out the savings.
You could do variations on that same commercial.
To a 5-week-old. I just read on the news yesterday that the hospital was hounding and sending parents to a collection agency while they're holding their 5-week-old baby.
And they're a not-for-profit hospital, I'm sure.
And I'm meeting with a film crew today at 3:00 in Ellensburg that wants to do a film project.
This would be such a low-level cost commercial to do. It really is.
I'm meeting with them
as
today.
a patient, I still have questions. So
good.
It's lovely. You're going to pay for everything. Where's that money coming from? Am I paying a bill, certain amount per month, like I do my utility bill? Is it based on usage, like my utility bill is?
Yeah.
Okay. And
that's the change in the finance, which is why it's a hybrid public utility. The fact of the matter is, healthcare is a national issue. It has concern for the federal government. It's chewing up state budgets.
Right.
It's driving corporations crazy. $1,500 of every car price you pay for a GM vehicle is because of healthcare. It impacts small businesses. And by small business, I don't mean the Republican definition. I'm not talking about hedge funds. I'm talking about actual small businesses that want to be competitive and bring people in. So they're trying to scramble to figure out how to cover these healthcare costs so they can offer benefits so they can get employees in that'll stay with them instead of just leaving.
So I get that concept.
It impacts cities. It impacts counties.
I get it.
You're paying taxes on your home. Your home taxes are covering public health systems. It's just all of these.
I get it. How
John, she's getting that. So get to the next question.
The next question you have to ask is, how many people look forward to going to see their doctors?
Not many.
Right. So is this going to be a situation where if suddenly there's no major overhead, you have to go to access healthcare, is this going to unleash an army of people come running in to get rectal exams? And no, people don't want to go to healthcare systems anyway, and they don't want to go to providers. Otherwise, they'd be going to providers, and they're not.
Here's my next question. How are you going to control costs?
But let's let's look at that.
How does the cost not continue to escalate? Because now I need a CT, I need an MRI, and go ahead.
So let's look at that for a minute.
Yes.
How are these things costed now?
On an individual basis, I can go to one CT place and it can cost me $1,000, and another place can cost me $200. Well, maybe not, but you get my point.
You go into the emergency room, you've got severe abdominal pain. They decide they need a CAT scan, and you're going to suddenly start shopping prices of where you're going.
No, I don't. I just need my CT scans to get it done.
Overwhelmingly, that's how people get trained into healthcare. I'm not talking about the shoulder replacement where you go pick your own orthopedist and he tells you need a shoulder replacement. And even in that scenario, you're going to the facility where they have privileges to. You're not going to be shopping around going, hey, you know what? If I drive 40 miles, I can get this shoulder reduction surgery done for $1,000 less. Let me just switch doctors and go to a new hospital again. That's not the way things work. I was a hospital triage nurse for, 8 years in multiple type geographic areas. It allowed me to see not just what was bringing people into ERs, but why they were coming into ERs. When you look at emergency rooms, when you walk in that door and sign that registration sheet, you're already $1,500 to $3,000 in the hole. It doesn't matter if they're taking a friggin' splinter out of your finger or they're going to end up referring you for surgery.
Right.
That's one of the charges you can get rid of. And
so how do you control that cost?
Okay,
how do you control that cost? Or how do we control the shoulder surgeon who is an independent practitioner and says, this is what I have to pay for the operating room. This is what I have to pay for the anesthesiologist.
Yes.
Go ahead. Go.
But that's not the way the system would work. These providers would be under salary. These are services now. You're not billing for, well, you can laugh, but believe me, I talk to a lot of doctors and they would be more than happy to trade off, $40,000 in income to restore some kind of quality in their life.
Yes.
If you think of a teaching hospital, this is the kind of model I'm proposing. When you're coming in, you're not admitted to Dr. X, you're admitted to a surgical service in that hospital. The hospital will have an incentive now to retain physicians that are quality focused because they're not going to have the throughputs that they had thrown at them under this for-profit system.
So basically, you're creating competition amongst the different hospitals and surgeons to be the highest quality, lowest price.
There's not that much competition to start with. You don't sit there and get sick and start shopping around on Google to see who has the largest cost. You go to the closest emergency room. When you're brought by EMS, they're not sitting there running up competitive billing for you as you're being driven into the emergency rooms.
No,
they're going to the closest facilities.
Or I'm looking for the best facility.
Stroke center or cardiac center, depending on what your particular problem is.
Right.
But let's get into the bigger cost issue. The overhead, administrative overhead, is now something like 33% of healthcare costs.
Yeah.
So we've got a system with senior administrators that have just written their own salary checks. We've got corporate systems over them. We have the boards over the corporate systems. And then we have probably 7 or 8 different LLC type corporations like Blackwater, I can't remember the name of it, that own them. All of those people are in training money out of these health systems. All right. That's going to stop. Okay. So there's a reduction now. And with nursing leading this multidisciplinary regional council, the administrative costs are going to be kept flat, because nursing typically prefers flat type administrations than it does hierarchical administrations when we have the option to decide them. All right, so we've got that level of cost. The insurance overhead is going to go up. So both to the complexity that the insurance industry brings into this system, the massive overhead that's put on providers to have to address 1,100 different types of insurance plans. I mean, this is just a stupid mess that's been thrust at the provider level. Plus, it stifles innovation because insurance industries will not pay a reasonable amount for things like preventative services and primary care, which is why we see all of that dissolving. They're not going to bring facilities and resources into rural communities because there isn't enough volume to generate enough profit to warrant their expenditures in those areas. So we've got rural systems collapsing. They're not going to go into neighborhoods that don't have high insurance rates because they simply don't get the reimbursement, and they have to spend too much, trying to get these people and trained into Medicaid and all this other stuff. And a lot of the incidents that happen in these lower socioeconomic areas tend to be more traumatic, and we end up getting more train wrecks in because we have zero preventative and primary care services going into those areas.
So how I imagine it is that, you know, in an area, you work with public health, you determine what the needs are for that area, and then that's how you create from a university type setting that becomes the regional healthcare provider. Everybody's working for that in terms of every avenue, prevention, wellness, all of that.
But let's keep talking about cost for a second, because there's more reduction.
Well, this leads to my question, because, you know, I understand that everybody's contributing to paying for that. How do you determine what a business pays, what the state pays, what the federal pays?
Be patient. All right. Another huge cost in healthcare is that because we're fragmented profit systems that don't communicate and don't work together, we end up paying retail for just about everything we buy in terms of supplies. There are some volume contracts out there, Tenet, HCA, some of these big corporations have a little more leverage in buying, but they're still primarily paying retail prices. In the regional systems, assuming that, say, there were 175 regional systems in the country, when they're cooperative, they now have the ability to say, you know what? We have 44 hospitals that need CAT scans. So let's come together and decide on the model we want, and then make these companies bid and volume for this equipment and supplies that we're going to purchase. All right. Again, I use the example all the time. You go into a BMW dealership and you tell them you want to buy a BMW. What are you going to pay? Retail. I go into that BMW dealership and tell them I want to buy 20 BMWs. You think I'm going to be paying retail?
No.
All right. Now let's look at another level, pharmaceuticals. We spend a huge amount, 1,300 times what most of the rest of the world pays in pharmaceuticals. We're also the largest pharmaceutical consumer in the world by far. So there isn't a single drug company that does not want to do business in this country. Congress is simply incapable of taking on these systems that are basically buying them. And we're talking $100 million a year. I think it was 2 years ago, it was almost $250 million given just by Big Pharma to the political process because they were worried that Congress was going to come up with pharmacy legislation. And what they ended up passing was that they would sort of work on 10 drugs, but that's not going to go into effect until 2023, 2024. These regional systems would be able to come together and say, yeah, you know what? We can competitively buy for these pharmaceuticals. So this is what we're going to pay for X product. What pharmaceutical company is not going to want to negotiate with those regional systems? It's probably 40% of their business comes into this country, period. I don't care where they make drugs in this planet. This is why Canada pays so much less for drugs. They buy bulk as a national health system. This is why England pays so little. This is why most of the European countries pay a fraction of what we pay for all this stuff.
Okay, so all of that makes good sense. It makes logical sense. Who's going to take on Big Pharma? Who's going to take on the insurance companies? Who's going to take these people on and just say, hey, we've got this system over here, and this is how many billions of dollars we can save in taxpayer funding? That
was my initial challenge when I started looking at this model to see, okay, what are the tactics to moving this forward politically? Fighting the individual politician battle is going to be very difficult. We got a bunch of Democrats that are strictly Medicare for all, and they're like cultists just as bad as anybody else. And that's led by Sanders and AOC and some people in Congress, We've got a kind of big chunk of Democrats that are kind of like the Biden Democrats that want to try to incrementally improve the PPACA. The PPACA as originally designed was actually pretty damn good. The problem is to get it passed, they had to compromise some things in there. And then over the next 10 years, the Republican Party and the Republican Congress just trashed it, took all the teeth out of this bill whatsoever. And then we had a huge chunk of states that didn't enact the deal with the PPACA, which left smaller markets then, which left the PPACA not as effective as it could have been. And now they're trashing the insurance systems again. So people are starting to get junk insurance all over the place. Mm-hmm. So we've got an incremental improvement in the PPCA possibility, but that's going to take 20, 30 years to get done. We've got half of our political system, which thinks it's a trap for socialism. And we've got half of our political system that has really not even been exposed to what we're talking about as even a possibility. So from the beginning of this group, I think I was pretty consistent in saying this. My vision always has been to get us empowered enough with the critical mass that we need, particularly things like nurse practitioner support or nursing group support or volume of nurse support, what I could consider
but the nurses are drowning. That's the problem.
I was just going to say, we've come back to the start, full circle. And
we're not going to get that.
Your American Nurses Association, National Nurses Association, they aren't doing squat. They're part of the problem. And then as Kathleen put, we've got nurses drowning at the bedside saying, somebody help me because otherwise I'm out. And a lot of them are leaving. So how do you fight the big machine, that you're talking about?
There's only one other route.
Mm-hmm.
And that route is to go public. Because the only other thing politicians fear, what they fear most is losing their elections.
Right.
Well, then that's what we need to do.
And that's what I've been saying all along. Is we've got to get into the public domain, put this model up there, and explain to people why it works for them.
Then that's our audience, John. And that's our audience.
But it takes money to get into the national media unless you kind of get this break. So, and that's what I've been trying to figure out and reach out to is how do we get that connection into, you give me a half hour on MSNBC and one of these Sunday shows. Let's talk about this.
Back to my question. How would you decide how much money the state, the federal, the businesses would pay?
Well, that would sort of depend on the anticipated budget of the regional system.
I can answer that question. I think that the state and federal level should begin by paying what they paid last year, and that the individual should pay according to their income tax return. And then every year, everybody pays less and less and less because the system keeps people healthier. That is my vision. And P.S., I have a direct link to Netflix. I spent, 15 minutes talking to an investigative journalist who told me she would propose a nursing something on Netflix. Then she asked me what I wanted. And it's like, once again, I'm like, what do I want? I mean, how about a talk show that's not that's with nurses, that it's based on healthcare, that is not as dummied down as The View is with the stupid, giggling, nonsensical questions? How about a 6-part series that answers the 6 major questions that Roberta asked?
Well, don't wear a stethoscope if you go on.
I'm going to wear 2. I'm going to wear 2.
The challenge, at least from my perspective, has been how can we get into this public discussion? If you're closed off from the political process, if there are so many people that are so siloed that they don't want to look around, they don't want to consider any other options.
Right.
If you look at medical doctors are convinced that they and only they know what's best for healthcare, and they don't want to hear anybody else's opinion. If you talk to nursing leadership is fractured politically, morally, ethically, in any other way you can think of. And they're just not able to conceptually see this need.
What if you start grassroots level? Certainly.
And that's the problem. There are over 800, how many, Kathleen? 850 different nursing groups all over the damn place in this country and all over states.
I'm talking about mayors and councilmen and starting at that level.
I already tried. I tried to do the Council of Mayors. I tried to speak. I tried to talk to them. I can't even get the public health folks to give us a call back.
I don't know that an individual city would be able to actually institute the public utility model. They kind of already do, in the sense that they already, on the homeowners' bills, they already collect money to help support their, like down here, Broward Health is tax supported out of property assessments. But it also receives state money. It also receives federal grants. And that's one of the big problems, is there's no real way to price what this would be costing if we just took away all the nonsense out of it.
This is why I just feel like there's such a tie into that Environ group, because if you look at their mission, it's to use the city of Louisville as an example of, really, to me, it says public utility model, but it's looking at a city and environmental factors that impact health.
Yeah, and that would be great if we could get into something like that. But the question then is, does that prove the public utility model, or does it prove that if you take an intelligent focus on a community, you can make healthcare work?
Right. If you take an intelligent focus on a community and you pay attention to the social determinants of health, if it is nurse-led, if it also includes prevention and nutrition, then it logically leads you to a public utility model.
Correct. It's the inevitable deductive logic out of the whole thing. Just like if you accept the goals, and the goals are the key to understanding the model. If you can accept the goals, the 7 goals for healthcare, the logical deductive model that will function to meet those goals is this model. There's no other model you're going to get to that meets all 7 goals.
Yeah, so just for the fun of it, all of you, I invite you to Google, what are the goals of the United States healthcare system? You want to have some
Please
fun?
do.
Yeah,
Make money.
There aren't any.
Please do.
Yeah.
And then
money.
Look at the 7 goals I put through. And you can even think every one of those goals down to the street level in communities.
So I'm going to go back to my analogy and ask a question. What we're saying to people is, you're drowning. I want you, and now I'm talking not just the nurses, but the person who has some kind of private insurance or has Medicare or Medicaid or both. And we say to them, we've got this great boat over here. You can get in this boat. I know you're drowning, but take off your life preserver first, and we'll pull you into the boat.
They don't have to take off their life preservers. They can get in the boat.
Okay. So
The current system doesn't have to be, the current system doesn't have to be eliminated. That's what the switch track model is. So the 10,000 cars that are going, imagine a train, 10,000 cars that is going towards illness and disease. That's the healthcare system. You don't just say, stop the train and turn it around. We want to go to wellness. You have to create switch tracks. So leave your life preserver on. The first switch track is nurse practitioner-led clinics all over the country with everybody having a primary care physician. The second switch track is identifying, getting your regional councils together, identifying the social determinants of health. The third switch track, aligning with universities, et cetera, et cetera.
I got that. That's good. You answered my question. Thank you.
If you look at the political process, we have an example of how this is done. If you go back to the electrical system in the 1920s and you look how FDR instituted the public utility model, there weren't just suddenly blackouts all across the country while we sat around for 3 months changing the system. What they did was they said, starting tomorrow, this is what your administrative system is going to look like. And you do the same thing in healthcare. And the power behind all that is CMS. CMS passes legislation that says, if you want Medicare money, this is what your administrative system is going to look like. It's done, because there isn't a hospital in this country can survive without Medicare and Medicaid money. Not one.
So then CMS is in charge of this process?
I've already talked to them.
CMS is in charge of dictating the structure.
Yeah, just like Medicaid and Medicare and Social Security.
It's not determining who or what occupies that position or what their goals are. It's telling the facilities that if you're going to be taking federal tax dollars as income, this is the process you're going to have in place to do this.
You must use best practice. You must be aligned with universities. You must have regional councils. You must have a caregiver for every single person in your community. You must identify the social determinants of health. You must actively have a plan to do them, etc.
Not that emotionally, but yeah.
Oh, yes, not emotionally.
So if you look at the model,
don't see CMS as being successful. I mean, Medicare and Medicaid are broke. So how successful have they been to get anything accomplished?
But that's the reason.
Yes, the reason I stopped my doctorate was to go get the MBA cert from Tulane because I wanted to look better at macroeconomics. And I talked to several economists back then. I haven't talked to any recently. When we ran the numbers on how this system would impact healthcare costs, it was a reduction of 42%. That means a 42% reduction in Medicare expenditure, 42% reduction in Medicaid expenditure, 42% reduction in the cost to states, 42% reduction in the cost to, right? So everybody, like take a pretty small state, it's like Oklahoma. Oklahoma is spending 20% of their state budget on healthcare. Let's drop that to 10%. When you look at businesses, the average business is spending somewhere around $1,500 to $1,600 a year to offer an employee health coverage. They can also be spending $4,000 or $5,000 depending on the size of the family and all these other variables. Right. Part of that money, the employee is also paying for that. Right. We pay for our insurance plans. On top of that, we're paying for Medicaid. On top of that, we're paying copays and deductibles whenever we interact with the healthcare system. And on top of that, we're paying exorbitant drug costs. Correct? So let's drop that business price down to a reasonable amount of money based on how much the company, you can even tier this stuff. So a major corporation might be spending $1,000 a month to cover the employee. They're already spending $3,000, so that's a savings to them. They don't have to worry about their retirees and pension plan because they're not going to have that overhead cost anymore to supply them a health insurance package. We're not going to need Medicare and Medicaid anymore, except as payment systems because healthcare is also a national priority concern.
It's not only a national priority concern.
States will be dropping down. Corporations will be dropping down. You won't have your monthly payment. And this can also be tiered based on income levels. We have to be realistic, right? But it's essentially, and there's different ways.
Then you start raising red flags for socialism, right? So that's what you're going to get from the politicians and the public. You start saying that I'm going to pay a certain amount, somebody else is going to pay a certain amount. I'm not saying whether I agree or disagree. I'm just saying that you wonder why people start going, oh my God, it's a single payer system. It's a socialism kind of program.
Yeah, but that's what we already do with utilities. I mean, what's the difference? Your electric bill?
Utilities are based on use, right? They're not based on your income. So yes and no. I mean, if I have a bigger home and I'm using my dryer, my washer, whatever, my lights, I have more lights in my house because it's a bigger house, then yes, I'm paying more. But I can also turn the lights off and have the option to not pay as much.
Well, you can also stay healthy and not have to use the healthcare system.
Well, yeah, of course, but I might get hit by a bus tomorrow, so I couldn't very well.
Exactly. And that's why this is so important. It's because healthcare is not a predictable commodity. I can't budget and decide which TV I can afford if I'm suddenly have thoracic mass in my chest.
Right.
What did you say? Healthcare is not a what?
It's not a commodity.
It's not predictable, a commodity.
It's not a plannable plan.
Right.
Which takes it out of the world of free market and commodity.
Right. So I still didn't hear the answer to how, what the answer is to, now you're socializing medicine because you're saying that I pay a certain amount, somebody else pays a different amount.
Now, what we're doing is individualizing healthcare to the fact that what you need and what your neighbor need are totally different. What you make and what your neighbor need are totally different. And this system is going to be able to accommodate all of that.
Then our tax system is socialist, you're saying?
No, it's based off of my income, right?
But I pay different taxes than my neighbor pays.
Yes.
Right. So
based off of your
the
income.
concept of taxation based on income is not alien to this country.
Right.
Okay. So we can kind of start with that point. So
this is a commodity that I'm purchasing that is a need.
You also purchase something with your taxes. Healthcare is the same way.
Yes, but I have relatively unlimited use of that. I may end up paying out of pocket for some of it, depending on what my insurance plan is. And I'm not saying this is fair. I'm not saying the system's fair. And I hear that that's what you guys are saying. I get that. It's not fair. One of the things I say all the time is, regardless of what we do, even if it's a single payer system, the people who have the money are going to know the people that they can pay, and they're going to pay for their surgery or their medication or their whatever. They're going to get what they want. It will never be a totally fair system. Fortunately, unfortunately, that's the way it is.
Roberta, the goal here is, see, every year our lifespan is less and less, and our country is sicker and sicker. This is a plan that changes that so that every year our lifespan is going to be longer, and our population is 50% of the people in America by 2030 are going to be obese. 50% are going to have diabetes, and 50% already suffer from one of the top 5 chronic diseases. We're a sick country.
We haven't talked about the administrative system yet. So what we've been talking about is cost, right? And the perspective from the person that would be involved. And we kind of all agree that there suddenly isn't going to be this massive wave of people wanting to go in and have surgeries done.
Right.
Human beings in general don't really want to go get prodded. It's hard enough to force them to go get a physical exam once in a while. I don't think that's going to change.
Right.
All right. So if we can work out a financial system where we get this 40+% reduction in costs across the board, we have salaried employees, everything from nurse practitioners to physicians, working under kind of a teaching hospital type mentality through the systems. All right. And as systems then now need an administrative structure that is accountable and is making good decisions based on data, not just on where they think they can put resources in place to make a lot of money. So in other words, needs-based.
Right.
So if we can go top down or we can go bottom up, might as well go top down because that's kind of easier, I think, to understand than bottom up. So in the United States, there's a certain reality you have to take into effect, and that is that we're a federated republic. You can't just put everything in the federal control, and you can't put everything just in state control, especially when you're dealing with something like healthcare, which has the potential to be interstate and all of this stuff. All right, so that's kind of a reality you have to accept. So what I put at, and it's not really even at the top, I hate considering that. What I put was a provider council at the DC level that was integrated with CDC and NIH as a communication vehicle between NIH and CDC through them to the state regional councils, but also function as a best practices collection portion to assess best practices in different communities, and then also get that information out to the state-based regions, because a lot of, problems in our communities, like rural communities, can be basically the same in multiple states, even though they may be quite different from other states. Does that make sense? So they're basically a funnel system of communication between the health agencies of the federal government and the regional councils, but they're also a communication system for the regional councils to each other.
I'd like to add that what I like the most is that you, just like electricity, you build an infrastructure, and the infrastructure that we would build in these regional areas by what people assess the needs are are going to address the social determinants of health. So that 40%, let's just take the Oklahoma example. So 10% of all that money the next year is going to be spent on high quality daycare centers and more hospices for seniors and et cetera, or whatever they decide it is. In one area, it might be a freaking swimming pool. They might have cardiac, and they're going to use evidence-based knowledge to make these decisions, and they're going to use the data that the government provides. But the government's job, the federal government's job, is not to control. It is to support. It is to give the data, give the information, share the information, share how one zip code is flipping its zip and they don't have diabetes and the other one is not.
Yeah, which we don't do.
We've become a collaborative ecosystem focused on the patient where everyone thrives.
When we talk about the payment model, I always use the example of the farmer. So you're a farmer and you have 1,000 acres to plow. Mm-hmm. The problem is your plow's broken. Does it really matter what you put in front of that? If you think of the plow as the healthcare delivery system, it's broken. Does it really matter what I put in front of that plow to pull it through the field? Does it matter if I use a team of horses or a team of oxen or a tractor, or in the case of Medicare for All, a nuclear powered tractor? What's my problem?
Or 100 people.
What's the problem?
100 nurses.
The plow's broken. Fix the damn plow. And then you can figure out the most efficient way to pull that plow through your fields. We don't do that. We keep trying to put something different in front of this broken plow and pull it along when we're not identifying what the problem is, which is the system itself. So that would be my argument.
Make more sense, Roberta?
It does. I wish I had the same kind of trust in the federal and state governments that you guys do. I don't think that you're corrupt to the core. And
this is not the Central Council is not a political agency. The Central Council
accountability and transparency
is made up of providers, just like the state-based ones will be.
Right.
The Central Council is elected by the regional councils to the positions they hold on there. They're not under an administration appointment system. Mm-hmm. So now you get down to the state regional council levels. These, to me, should be situated in teaching hospitals. And the rationale for that is I want a direct link between these councils and the universities so that we can start moving evidence-based practice into practice in less than a dozen years. The other advantage this is it opens up the entire regional area of healthcare to students in in the healthcare professions. They can go do clinicals in rural counties. They can go do clinicals in urban counties, different types of urban areas, suburban areas, so that these practitioners that we're putting out there are holistically trained in healthcare. And as we'll see in a minute, also aware of and engaged with the social and the economic determinants of health. Mm-hmm. On that state-based regional council sits people like public health.
Like you.
Because the relationship between public health and nursing, I mean, when you think about it grossly, somewhere around 95% of what we're talking about in terms of healthcare delivery is nursing services.
Right.
That's just simple truth. All right. So if 95% of it is nursing services, why isn't nursing in charge of determining how to best apply those nursing services to the communities we're serving? That's why nursing sits as the chair of these state-based regional councils. Now, everybody's at the table. Medicine is certainly at the table. Surgeons are certainly at the table. Infectious disease doctors, mental health experts, long-term care people, EMS. We're all at this table to make the decisions of where resources are allocated. And in public health case, collecting data from these communities to determine what are the major needs. The other big advantage of reconnecting nursing and public health is that then it also provides providers in the field who can now relay information they find directly up to get into public health. So, example, the home nurse goes to an apartment in some inner city somewhere. And they go up and they find out there's still lead paint on the wall, or that they don't have clean drinking water in this building, or that the place is deteriorating and there are rats running around it. Those reports can go right to public health and come right back to start holding these landlords accountable to provide safe, clean housing to people if they're going to do it. So in other words, that feedback loop starts getting set up between public health and its job of assessing community health risks and projecting, the paths of disease in communities to the regional councils. And you also have this nursing workforce, and especially the innovation it's going to release, and the part of nursing and direct care providers to be able to funnel information almost real time up to public health so it can respond to social and economic, well, certainly social and physical causes of, health risk. The central regional council in that state oversees what I call the large hospital system, which is in their zone, the full service hospitals. Those hospitals have councils running them. Those hospitals oversee the district healthcare resources within their districts. And, we talk about one of the challenges I get is, well, how do we divide states up into districts? My God, we have 100 different ways we do that already. I wouldn't recommend voting districts because they've just been so gerrymandered that they're stupid at this point. But we use zip codes. We use telephone prefixes. There's a whole host of different ways we divide up states into regions, counties. So we can solve that problem. It's not unheard of. The regional council will have also the direct responsibility for rural areas within their zone. And the reason that needs to be done, I think, is so that regional council keeps a holistic focus on healthcare in their region, so that they don't just isolate themselves to think about the 7 or 8 hospitals that they're familiar with right outside their doors. They're forced to also have to take the perspective of rural areas in this country. So that's a priority as well. I think that's kind of a critical step.
Not only that, I believe the entire plan builds on the nature, the culture code of Americans, which is that we're pioneers. And that pioneer spirit and that creativity and that competitiveness. If anything, Americans are known for creativity and competitiveness, and it takes that rugged individualism and it provides a common light. The regional council is a common place where people can be proud of their local areas, because we're certainly not proud of our country. Yesterday was Veterans Day, and all I could think of was, I want to be the country that those hundreds of thousands of soldiers died for. I want to be that country.